So here we are going to discuss the hypothyroidism station. A 35-year-old lady with a neck swelling, lethargy, malaise, lab shoes, low T3, T4, and high TSH, which is for sure hypothyroidism. Anemia as well. 65-year-old woman presents with long-standing goiter. She also described general malaise and chronic fatigue, low lab shows T3 and low T4 with high TSH and anemia. What is the most probable based on the labs and clinical picture? So most probable diagnosis are primary hypothyroidism draw and okay, so draw. Okay, basically explain, and you if you can draw the hypothalamic pituitary thyroid axis. So basically what happens that we have the hypothalamus. Yes, the hypothalamus, and hypothalamus it secretes the TRH, thyroid releasing hormone, pituitary, into which acts on the anterior pituitary. Anterior pituitary secretes the TSH, thyroid stimulating hormone, which acts on the thyroid follicles, and the thyroid follicles then further form the T4 and T3, and this is released in the bloodstream, where T3 is the active entity, and works on the act on the different cells to execute different functions. So what are the differences between T3 and T4? So T4 is solely secreted from the thyroid gland, whereas 20 to 25% of T3 comes from the gland, and remaining comes from conversion from T4. So earlier we discussed that T4 is converted in the peripheral tissues to T3. So only 25 to 30% or 20 to 25% comes from the thyroid gland. Rest is by conversion from T4 to T3. T3 has a half-life of 1 day, T4 7 days, and in peripheral circulation T4 comprises 93% and T3 is only 7%, and T3 is 4 times potent than T4. T4 is more protein bound than T3. So basically T4 is more protein bound. This means that T3 is the active and the function entity. Type of anemia in this case, so macrocytic anemia occurs in hypothyroidism because pernicious anemia lack absorption of vitamin B12 due to antiparietal cells antibodies, leading to lack of intrinsic factor. So if they ask you that what kind of anemia will occur, because in the scenario they are saying that the patient is anemic, so it will be most probably the microcytic anemia. On peripheral you will get the large macrocytes. So the earlier we discussed in the other station, the hyperthyroid station, that iodine, this is the mechanism or the steps in the formation of thyroid hormones, that iodine in the cells is taken up by thyroid follicles and it's converted the iodide is converted into iodine. So if someone wants to understand that what is iodine and what's iodide, basically, so iodide is the is actually the oxidized state, which is AI. So if you remove this charge from the iodide, you will get the iodine. So iodine is formed in the thyroid follicular cells, and this iodine is then matched or combined with the tyrosine. The tyrosine by the thyroid peroxidase enzyme, and so this leads to the formation of monoiodotyrosine and diiodotyrosine moieties, and then they further combine with each other to form T3 and T4. So the thyroid secrete two major metabolic hormones, the thyroxine and the triiodothyronine, commonly called T4 and T3 respectively. So T4 is thyroxine, and tri, as the name shows, it is T3. Both of these hormones profoundly increase the metabolic rate of the body. About 93% of the metabolically active hormones secreted by the thyroid gland is the thyroxine, and 7% is triiodothyronine. However, almost all the thyroxine is eventually converted to triiodothyronine in the tissues. So triiodothyronine is about 4 times as potent as thyroxine, but it is present in the blood in much smaller quantities and persists for a much shorter time as compared to with thyroxine, because the T4 has a half-life of about 7 days, whereas T3 has a half-life of about 1 day. So these are the mechanism of the formation. So we have the apical membrane collide. So the iodide is converted to iodine then further combines with the MIT, monoiodotyrosine, and diiodotyrosine is formed by the tyrosine or thyroglobulin, which is present in the thyroid follicles. So okay, so this is basolateral membrane perifollicular capillary. So this is the blood, this is the cell, and this is the collide. So basically thyroid cell is like this. I have explained in the other video as well. So this is one cell. Let's suppose this is the one cell, and here is the capillary, and this is the center collide. So we have iodide, sodium iodide. So the sodium iodide symporter, it transfers the sodium and iodide in the cell, and this cell is then iodide is then converted to iodine, and then this is combined with tyrosine and by the peroxidase enzyme to form T3 and T4. Okay, so these are then again transported into the follicular cells, where they are formed by the into diiode or thyroxine forms, and then they are secreted when needed, T3 T4. What are the causes of hypothyroidism? So primary hypothyroidism, so it can be autoimmune due to Hashimoto disease, in which the antibodies are formed against the TSH receptors. So iatrogenic, because of surgery, you do thyroidectomy, you remove the thyroid, then you will get hypothyroidism. Radioiodine therapy, which will damage the thyroid cells, and antithyroid drugs can also cause. This can be caused because of the iodine deficiency, which can lead to goiter, and we have the idiopathic sometimes, and genetic defects in the thyroid development, and sometimes you don't have the proper enzymes, which are the genetic disorders. For example, the peroxidase enzyme. Thyroid hormone resistance syndrome. So sometimes your body cannot act or responds to the thyroid hormone. So this is basically a hypothyroid state of functionally. Congenital biosynthetic defects, dysharmogenetic goiter, and transient thyroiditis, recurrent thyroiditis, in which is a viral condition in which there is hypothyroid state, infiltrative amyloidosis, sarcoidosis. The thyroid hormone is infiltrated with misfolded proteins, and it can lead to hypothyroidism. Secondary failure is because of the pituitary failure. Pituitary is not secreting TSH, and so we have got the secondary hypothyroidism. Hypothalamic failure, and this is the hypothalamus. So the THR, thyroid, as we discussed here, so TRH, thyroid releasing hormone, is not secreted by the hypothalamus, which can lead to secondary hypothyroidism. If this patient has hypothyroidism as a result of hypopituitarism, how will the TFTs be different? So T3 T4 will also go down, but at the same time TSH will also be low, because pituitary is not secreting it. And if there is a problem in the thyroid gland, so T3 T4 will be low, but TSH will be high, because pituitary will be constantly stimulating because of the low thyroid state. Patient with hypothyroidism not compliant to medications comes from an emergency surgery. What are the risks? So preoperative, he will have anemia, increased risk of ischemic heart diseases, and intraoperative, there can be bradycardia, hypotension, hypothermia, which can lead to coagulopathy and airway compromise. Postoperative, delay recovery from anesthesia, confusion, myxedema, coma. This can lead to this is a profound manifestation can occur in hypothyroid people. So we can have the myxedema, coma, poor wound healing. So what are the clinical features of hypothyroidism? So the patient will have weight gain, dry skin, alopecia, and cold intolerance. memory loss, constipation, eczema, muscle weakness, and peritibial edema, hoarseness, deafness, cardiomegaly, bradycardia, hypertension, menstrual disturbances. So all these can occur in hypothyroidism. Opposite of hyperthyroidism. Causes of anemia hypothyroidism. So thyroid hormones are required for proliferation of erythrocyte precursors, erythropoiesis. So hypothyroidism is associated with depressed bone marrow stimulation. Thyroid hormones increases erythropoietin gene expression. So this is another reason. And nutrient deficiencies, for example, iron, vitamin B12, are because of the autoimmune antibodies against the intrinsic factors. In autoimmune thyroid status, concomitant pernicious anemia can also occur, and atrophic gastritis. Who to involve in care? So endocrinologist, anesthesia consultant, surgical consultant, and radiotherapist. How to increase patient compliance with treatment? Discuss with patient the reason for non-compliance, social or psychological reasons, communication with GP and family member, medical follow-up, and simple regime. For example, make the dose single, not divided, and to make the dose of replacement in the early morning, so he won't be worried the rest of the day. Okay, so emphasize that relapse is inevitable if therapy is interrupted. What are the indications of thyroid surgery? So toxic nodule, indication of thyroid surgery. So toxic nodule refractory to medical treatment, large multinodular goiter which is symptomatic, thyroid malignancy, obstructive symptoms. FNAC cannot differentiate between benign and malignancy, so you go for a thyroidectomy or lobectomy, cosmetic purposes as per patient's wishes. So this was all about the hypothyroidism.